PIEZO.
The PIEZO.
PIEZO knife, PIEZO tome. The PIEZO tome is the proper name for it.
And what basically does it do, doctor?
It is essentially a knife that will cut through the bone and it will cut through the suture, and it will help to loosen up the connection of right and left half in the upper jaw, in the maxilla.
It's probably scary for a patient to think, oh, am I going to have to go see a surgeon? Will they have to go see a surgeon, or is this something you do right here in the office?
I do it right here in the office. It's, chair side. It's very simple. It literally is very simple.
Stupid question, but do you do this before you put the appliance in?
Before. Yeah. So the procedure is patient gets in the chair, we numb the patient up, then I do the PIEZO, then we put a dressing. Once the dressing is in, then we insert the expander, and then we put the TADs.
Wow. That's a long afternoon for that patient.
It's about an hour and a half.
Damn.
So not too long.
It gives me the heebie-jeebies just thinking about it. Show us what's going on here.
So that's a PIEZO knife. It has different tips.
Mm-hmm.
You could, there's this one is a square. There's one rounder.
Oh, it's actually got a jagged tip that looks like like a saw blade.
Almost, but so that tip vibrates, and then then what you do is when patient is numb, you just go right in through the middle.
Yeah.
Like that, gradually, obviously not that fast. And then you go down this way.
You're holding it like a pen, so it's a delicate procedure. The tool does all the work.
That's pretty much, yes. There's no pressure. So you essentially just go just like this. And then you go above the teeth, straight into the nasal spine. So essentially releasing that where the biggest resistance to the expansion is. And with the proper design and with the proper planning, the issue of splitting is no longer an issue. The recovery is uneventful. If someone's thinking that it's a scary procedure, and I thought so initially too, until I saw a dome procedure done when the surgeon took a chisel and started whacking it into the patient's head. So, which is a lot more invasive.
Right. So you do go right through the skin. Is there any bleeding?
There's no bleeding.
Why not?
First of all, there's not a lot of blood vessels where we cut.
At the roof of the mouth.
At the roof of the mouth. But even here, somehow it probably has something to do with the ultrasonic nature of the PIEZO tome that it doesn't bleed.
So the knife itself, it doesn't actually cut because it's sharp. Does it cut because it
vibrates?
It's a vibration.
Yeah.
Is it a heat or is it a vibration?
No, just vibration, no heat. I mean, it gets hot because of the vibration, but it's there is a cooling mechanism that comes with it. So we don't want it to get hot. And I'm certainly not a pioneer in it in any fashion. I probably one of the first ones who started applying it to the MSE or skeletal expansion. But PIEZO has been around on the market for a good 10+ years. It's usually used for keratotomies, SFOTs, and extractions, sinus lifts. It's been used forever.
Which is to say, you're seeing near perfect success rate.
I haven't failed this year yet.
Out of roughly how many cases?
Not very fair question because it's close to an over 150, but not all of them are adults or adult males. Maybe a good third of them.
And are you using this even on patients who aren't adult males, let's say? On younger patients or female patients?
My cutoff, I would say anyone over 25 will get it done. Males 25 and females around 30+.
So this tool has basically taken one of the biggest uncertainties with MSE treatment and eliminated it.
In my hands.
In your hands. And so is it a skill-dependent appliance? I mean, is it...
I think there's just, there's a couple other things that go into it. Placement, the design, because as you know, I customize my own MSEs very frequently, or I order them customized. So, the manner of where the TADs are placed and engaged is, I think, is critical, just as critical as PIEZO.
And how do you determine that?
From a cone beam.
So every patient is different.
Every single one.
You can't generalize and say better to put it, right in this spot between these two teeth, or further forward or further back.
No, it's a crapshoot.
It's unless you're actually looking at the bone of the individual patient.
That is correct. You need to look at it. Right. If you don't use practitioners that don't use cone beam and just guess, between premolars and molars in a certain area, it's a guess.
So what do you see on the scan that dictates where the appliance goes?
Where the bone is and the thickness of it.
And do you want to put the appliance sort of in the thicker area?
Yep.
Because
at
you
least
want
not necessarily the appliance itself, but sometimes you need to add more TADs, or you need to have some supports on the sides in addition to along the midline. So this way to make it properly successful, because sometimes the bone in the palate in the middle is too thin.
right. So is the idea you want to put the appliance in the area where it gets the most bite?
Pretty much.
That way the TADs don't drag through the bone.
Yep.
Because is bone drag or screw drag, I think they call it.
Yeah, correct.
Is that the primary reason MSEs have failed?
Most
generally?
of the time.
It's not that the bone is just too hard and the TAD bends and folds. It's
a combination of multiple things. I think the failures, and again, as you know, I do teach it in my course, and then I have a couple of hours on just failures alone, which
Wow.
I've had plenty. And I present all my failures, and then for what I've got from my own failures, anytime the screws were too far back, and without PIEZO, there is the bone is just too thin, so it starts to drag. Sometimes I hear people started to turn like 6-8 times a day. This is, I think, to me is insane. And essentially what starts to happen if you put 6-8 cranks and the MSE starts to bend, the minute it starts to bend, because the resistance is too great, you got your TADs going this way right away, you're done. It's not going to split.
so what does turning slower? Why doesn't turning slower do the same thing?
Turning slower, it gradually transfers it doesn't start bending the MSE right away. It transfers the pressure to the bone in a gradual manner. Kind of gradually builds it up, and then splits, rather than just, because I think once you do a lot of turns right away, it just starts to bend right away, and then once it starts to bend, it's finished.
So there's something about distributing the force over more time that is beneficial to the appliance having success.
Yeah, and Dr. Ting was actually probably the first one who's talking about slow expansion protocol. And again, in my own hands, every time I try to do more than one or two, it always fails more often than not. Sometimes I had to just backtrack and start slower, and it worked second time.
So if you could give a rule of thumb for the ideal turn rate with the MSE from start to finish.
Once a day.
End of story.
End of story.
The right answer usually is an elegant one. One turn.
One turn a day.
Simple.
Very simple.
How do you screw that up?
You can't.
Right?